how that goes. The good news is that we are committed to trying to video record both the sessions, so we will have it captured. So if you miss one and you want to capture it with the video, you can seek us out for that information. I just have two quick housekeeping kind of pieces that I want to address, and then I'm going to turn it over to the students for the remainder of the day. The one is just to let everyone know that PT Advanced is coming today. Our university relations people were very successful in reaching out to them and explaining to them the mission of the conference and the fact that we have 19 schools represented here doing wonderful things across the country, and they got excited about it. So apparently we're going to be a featured story on the front page of PT Advanced, perhaps in April. The camera will be here between 10:30 and 12:30, capturing pictures. So if anybody is uncomfortable with their picture being taken and potentially being on front page of national news, let us know, and we'll make sure we respect that. If not, smile for the camera, and also be ready to share your contact information. I don't know that they're going to have an interview person here, but they will be wanting to know how can we contact you so that we can hear more about your project, more about your clinic, more about your school. So be ready with a business card. It'd be great. We want to make sure everybody has a chance to have an audience with them for this right afternoon. Speaking of pictures, we have some cameras that will be here through the day. Dr. Sandy Campbell is over here now. She's one of our faculty members, and Dr. Bob Bowman will be here this afternoon. We like to try to capture the event with pictures, and so we usually try to make those available to you as well after the conference. And then the final person I want to acknowledge is going to be Renee Malone, who is going to be coming from APTA. She called me just a little bit ago. She's here? Renee, there she is. She made it. Thank you so much. That's great. That's great. I wasn't sure if you could pop in, and that's perfect. So Renee is here, and I'm so excited that she's here. I think it's great to see APTA's support of us, and we're definitely on their radar, and we want to stay vice versa with them. So please introduce yourself to Renee. She's eager to meet everyone, and to see what connections we can do in terms of furthering promoting physical therapy in our profession. So with that, I think I covered all the main points I was supposed to cover. Is there anything else I'm supposed to cover? Great. The last piece that I want to introduce is the Widener students that are here. Widener students, if you guys could all stand in some capacity. Some of them have blue shirts on, some of them don't. We have a closet full of blue shirts. So that's how it rolls, right? The first people that got to the closet first got the blue shirts. But thank you guys for all of your help with it. You're going to meet several of them formally here up front throughout the day. Please go to them with any questions and any guidance that you need through the day, where's the bathrooms, etc., all that kind of stuff. They can tell you that. They can tell you where to go for the St. Patty's Day parties later tonight. If you want that, I'll stay out of that. All right, with that, I'm going to turn it over to Nicole Nardone, who has been our conference organizer this year.
Hi, like Bill said, my name is Nicole Nardone. I'm a second-year PT student here. I'm like the outcomes coordinator for our clinic. I just wanted to go over thanking you all for coming. This is awesome. Just want to go over logistics of the day. Like in your packet, you have our schedule and stuff. Just want to explain the breakout session concept really, because this is a little different than what we did last year. So we'll have the keynote speaker will be in here, and then when we go into those breakouts, there's a list of all the oral presentations in your packet, and that has a room location for when that presentation is happening and where it's going to be. They'll be within this room, and then room C, it's right down the hall on the right. There's balloons outside marking that. I just wanted to say, so you get to pick your topic, which one you want to go to. You can go in between the breakout sessions if there's one in the web room you like, and then the next time slot you want to go in room C, it's perfectly fine. Just like if you see like the room's getting filled and you have 6 members from your school there, maybe you divide your school up so that way we can get as many people in both rooms as possible. For lunch, we wanted to just thank Aramark. They provided all the food for us today, and we're actually going to have lunch in our cafeteria, so that way we have a wide variety of options and everything. And that's down to the right, like when you walked in, you go straight past the posters and over there. And when you get there, you just mention that you're with the conference, and they'll let you right in. Poster presentations will be going on simultaneously during the lunch hour, and you guys all hung up your posters out in the atrium, so we're going to ask that you just stand by your poster when you're finished eating and kind of open that conversation there. So as people are going and coming from lunch, it's kind of just an open time to explore everyone's presentations. And then tours at the end, if you signed up, I think we had 30 people that said they wanted the tours, so we'll gather here, and then we'll have a shuttle service over to the clinic, and we'll do the tours that way. Bathrooms, there's one, like a single bathroom down the hallway right here on the right, and then there's also, if you go past all the poster presentations down to the left, there's another set of bathrooms there. You need to access those throughout the day. Another new thing I want to introduce now that we're doing this year is we've created a Twitter account, and it's going to be, we're going to encourage people to follow Chester Community PT on Twitter, and like throughout the day tweet things at our thing, and then hashtag the PT network, and we're going to try and do like an interactive day, and we'll have like a live feed in between the presentations. Do we have them? So that way, okay. So it's kind of something that we're going to talk a little bit more about what we plan to do with this later on, but we're going to give a prize for the person that tweets the most today, and then we're going to go from there. We'll have them call it up right with So, and then we need help with creating a Twitter. I can go over that with you at lunch if you don't have one. But this is going to be, you can ask questions about the presentations. You can just tweet like a fun fact that you learned, like, oh, awesome presentations. We put a PI earlier, learned this. Takeaway messages just throughout, and just hashtag the PT network, and that will be all on the same feed. So just send that hashtag at the end of all of them, and then we'll kind of keep that live and interactive today. And another thing we just want to say, so one of the raffle prizes will go towards the person who tweets the most for that. And then we'll also have other raffle prizes of like iOrtho apps and actual ortho notes. So we're also going to sell extra raffle tickets. You all have one that you got for the door prizes, but at lunchtime we'll sell additional ones. That'll be $1 per ticket or 6 for $5 if you want to increase your chances to win those. And yeah, so get ready to tweet. And I'll bring up Brian Kennedy now to talk about some of the other stuff for today.
Okay, so thanks all for coming again. Just want to let you know we have an additional 5 virtual attendees, which will be seeing this all day, video, PowerPoint, and also be hearing you speaking from the PowerPoint. We have people from University of Montana, University of St. Mary's in Kansas, Elon University, University of the Incarnate Word from San Antonio, Texas, and there's also another clinician from an unknown location at the moment.
There's always a mission.
On top of that, we have 19 schools attending here, which is a big jump for us. We have Bellarmine University. You guys, where y'all at? All the way from Kentucky. Quinnipiac from Connecticut. Evansville University from Indiana. So back there. Wayne State University from Detroit. Lynchburg and Shenandoah University from Virginia. Wheeling Jesuit from West Virginia. Columbia University and Nazareth from New York. Rutgers University from New Jersey.
Woo, go Rutgers!
Chatham University from Western PA. Drexel, Thomas Jefferson, Lebanon Valley College, and Widener from Eastern Pennsylvania. So, anyone look bring out our next speaker, Christina.
Hi, my name is Christina. I am the clinical coordinator for the PT 3 class, and we're graduating in May. Really excited. First, Jill wanted me to announce that the faculty, they are invited to share a lunch table at lunch if you would like. So just try and find Jill, and then you guys can sit together and network that way. First, I wanted to talk about the goals of the event. You can find it on this paper in your packet. It's just like a little overview. And then we're also going to introduce the keynote speaker, which is on the blue paper, a little bio about her. So first, I just want to say thank you for coming. We're really excited that you're here. We're really happy that we got to have our second annual networking event. It was great last year, so we're hoping it's going to be great this year again.
So for the goal for the conference is to have a networking atmosphere, if you got that vibe. We have around 19 schools, which Brian announced. And basically we want you to try your best to network with students and faculty throughout the day that you may not know. So at lunch, try to sit with people that you don't know so that you can network about pro bono services and that you can learn about them. And if you haven't opened a clinic, you can talk to people who have started a clinic, and it's a great way to learn good things and bad things about opening a clinic as well and helping your community. Also, if you have any questions for the Widener students, we're wearing the blue shirts that you've seen, so just feel free to ask them where the bathrooms are and where the lunch is and the posters, anything you'd like. Okay. So the next thing I wanted to say was the keynote speaker. First, we wanted to tell you thank you so much for coming. We really appreciate that you're here and that you're willing to present for us at this conference. And her name is Sarah Wenger. She's a physical therapist at Drexel University. A little bit about her: she has been practicing for 13 years, and she coordinates fitness, prevention, and physical therapy services within a transdisciplinary model for people with chronic conditions. So without further ado, I'd like to have Sarah come up.
I don't know if I would admit it, but it's actually been 17 years. But that's off our Drexel website for a little while. So we didn't care. So, this one moves forward. Got it. Okay, so I'm just going to say I normally pace around a lot, but since we're webcamming, I can't pace, so that probably means I'm going to flail my arms a lot or something. So I just a little bit more about me. I work at, I teach at Drexel University, and as part of my appointment there, I do 2 days a week at a pro bono clinic called 11th Street. It's a huge transdisciplinary model there, so we've got primary care, dental, community outreach, community education, a lot of mental health services, and a lot of mental health support. So I'm completely spoiled in that sense. So I've been there for about 6 or 7 years, and then prior to that I worked in a hospital that had a largely underserved population, so a lot of Medicaid. So I've kind of just sort of grown up with this population. And I've been doing it my whole career, and it's certainly a passion of mine, so I'm very thankful to have been asked to come here. So thanks Widener, and thanks Jill and Robin and the students who do such a good job here. I'm really pleased to be speaking on this topic. I'm going to sort of zip through a couple of things that just kind of set the scene. I think most of you guys already know this. Why are we doing pro bono? You know, our association asks us to. It's in our code of ethics. It's in our core values. This is a nice little article. The Public Health Association looked at healthcare during an economic recession, which is what we've got going on right now. And it's a nice article. They outline a bunch of stuff, but the basic gist of it is there's more need and there's less resources. So we're really at a time right now where I think this is particularly pertinent. Certainly there's Healthy People 2020, which has a whole lot of objectives that we are really focused on in serving the underserved. So all of these things are more challenging in the underserved population. So I think those of us who are working in pro bono are really taking this on with the most challenging patients. So I'm going to introduce you to Medea. This is an actual patient of mine, and she did choose her. I let her pick her fake name, and that's what she picked. I went over this whole case with her so she knows what I'm presenting, and was happy to have me do it and happy to be a part of your learning. So I'm going to introduce her, and then I'm going to sort of thread her through as I talk, but it gives you an idea of just the level of complexity that we see in an underserved population. And then I'm going to talk to you guys a little bit about why we see that level of complexity in a pro bono or in an underserved population. So as you can see, she has multiple areas of complaint, you know, back, neck, shoulder, hips, knees. And if you guys have been doing some pro bono volunteer hours, you've probably seen this where they come in with a script for, you know, whatever, knee pain or something. You go through the whole history, you get to that point where you say, is there anything else you'd like to tell me? And they go, oh, well, my neck hurts, my back hurts too, and my foot hurts, and I have, you know, on and on and on and on. So we see in the underserved population, many areas of complaint. Also, multiple system involvement. So she's got issues in pretty much every system. Some are more, GERD's not that big a deal, but then multiple strokes and centralized pain syndrome, pretty big deal. So she's got involvement along all of her systems, so very complex. Adding to that, this is the part people tend to look, we tend to just kind of breeze over, we're not mental health professionals, but just a tremendous psych background and a lot of mental health struggles and a lot of childhood trauma. One of the things I'm going to talk to you about today is how childhood trauma affects adult health, and the portion of people that you're likely to see who are going to have childhood trauma in their background. The statistics on that are pretty staggering. So she's got a history of a lot of things, and then she also has some current things going on with her husband in jail and of the recent death of her mother. Also socioeconomic and environmental concerns. She's very low income, and with her husband in jail, that was most of the income that now she doesn't have to work with. She has a really hard time negotiating public transportation because her balance isn't great. She can't really tolerate the walking, and she's fallen several times on the bus. So it's really hard for her to get around. It's really hard for her to sort of just negotiate normal ADLs, keeping the house clean, getting fed, that kind of stuff is really challenging. And then she's just generally struggles with health and wellness. BMI of 48, really poor fitness, she's a smoker, and her diet's pretty bad, and a lot of the things that we've talked about are sort of contributing to why her diet's bad. She has difficulty accessing fresh produce, and then she also has difficulty tolerating cooking, so there's more prepared meals and stuff like that. So I don't mean to depress you guys, but you will see this a lot when you're working with the underserved, where it's just complicated in terms of multiple body parts, multiple systems, but also all the social and economic and all of the sort of mental health and life challenges. So you see all of that wrapped up into one person. And I give a sort of similar lecture to our students, and I always say this is the patient that walks in and you go, oh my God, what do I do? Because it's pretty overwhelming. And so what I always say is if you feel overwhelmed, Medea has to actually live with this day in and day out. So you being overwhelmed just because you're hanging out with her for an hour does not necessarily help her out at all. So what I hope at the end of this talk is that you feel like you have some tools to help the patient like this, and that you can take off a little bit of chunk and you kind of know what to do instead of feeling completely overwhelmed and not able to help somebody like this. What I hear a lot when I talk is like, oh, I can't help patients, that's a lost cause, like they just shouldn't be in therapy. So I hope that you don't feel that way after this talk. I'm taking it that most of you don't, because you're all already interested in serving the underserved. So just want to talk a little bit about who shows up in a pro bono clinic, generally speaking. So obviously people with health disparities are going to show up because they're the ones that are not insured and not getting physical therapy otherwise. So racially and ethnically diverse, lower income, lower education, typically more women than men, and rural, although that certainly doesn't apply to me at 11th Street. You're going to see people with a lot of chronicity. That has to do partially with some of the childhood trauma issues, but also certainly with the lack of intervention and the lack of access. So people who don't access healthcare and don't access healthcare early are going to develop more chronicity. So you will see a lot of chronicity, a much higher portion of chronicity in a pro bono clinic. And then people with childhood trauma, so I'm going to get into that now. There's a study done, has anybody heard of the ACEs study? Adverse check, oh, excellent, okay, you've heard about it now. So this study started, it was a weight loss study that they did out in Kaiser Permanente, which is an HMO, so they have lifetime access to a huge number of records. They were doing a weight loss study, and they were looking at their dropouts to see who was dropping out. And I guess their theory going into it was people who were dropping out wouldn't have lost weight; they would have been unsuccessful. And they actually found that a lot of the people had lost weight. So they started doing some detailed interviews about why people dropped out. And what they found in these interviews was a ton of people were reporting childhood trauma. And for the obese population, there are a lot of sexual abuse as children, and there was a lot of stuff associated with that, like concerns about, the weight gain was to sort of be less attractive, to sort of thwart those advances, and there was a lot of fear about losing weight, becoming more attractive. Would that garner some attention? Would they be able to handle that kind of attention? So there was all of the psych stuff going on that was a barrier to weight loss. So they thought the portion of people reporting childhood trauma was so high that they looked at it a little bit more closely, and they did a huge retrospective study, more than 17,000 people. They gave them that questionnaire that you have. You should all have the ACEs questionnaire. I would definitely encourage you to take it and figure out your own ACE score. All the study information, I gave you references, are on the other side of that piece of paper, so you can go to acestudy.org and look at the questionnaires there. The CDC website has all of the different articles that they've done. There's tons of different articles. But basically, they sent people this questionnaire. They got over 17,000 of them back, and then they correlated that questionnaire with their adult health. And I'm going to show you what the results were in a sec. We redid this at 11th Street. So the original study was done in basically a white middle-class neighborhood in California, and we redid it in a primarily African-American, low-income North Philly neighborhood. And we had 800 subjects, mostly women. So the ACEs are split into 3 categories: abuse, neglect, and household dysfunction, and you really get an idea of what it takes to get a point when you look over the questionnaire that I showed you. So these were all the things that were associated with ACE score. So the ACE score was associated with mental, social, and physical health issues really broadly. Okay, now it's obvious that some of those mental health and some of those social health concerns are probably the things that led to the physical health concerns. But the relationships with all of these things were pretty stressful. The statistics on this, honestly, are amazing. I mean, I'm not going to quote them all for you, but you can go look them up. They're incredible, and they're dose dependent. So, for instance, for attempted suicides, they said that the ACE score alone by itself, without any other factor, was predictive, somewhere between 60 and 80% for attempted suicides. And that's an incredible statistic. So I think the take-home point here really is childhood trauma, no matter how long ago it was, absolutely has a tremendous effect on adult health. And if you're working with a population of people that have childhood trauma, this is evidence you need to know. We talk about evidence-based practice. If childhood trauma has such an incredible effect on adult health, that is absolutely evidence that you should be basing your clinical decisions on. So this is the study. There's my pointer. Yeah. So in blue is the original study, in red is the study we did at 11th Street, and you're going to be, the results are amazing. So about a little over a third of the people in the original study had 0 as an ACE score, and 6.3 at 11th Street had 0. That's a tremendous difference. And if you look up here at 4 or more, 12.5% in the original study, 49, almost half of our patients have an ACE score of 4 or more. And when you look over that questionnaire, that's pretty serious. I mean, that's not it's not light stuff. And then I sort of look at, like, if I sort of take divorce and separation off the table because it's so common, and we started an ACE score of 2, 82-ish% of our patients had ACE score of 2 or more at 11th Street. So I think if you're working in pro bono, it is likely, I can't say for sure, but it is likely that your statistics are going to fall out a little bit closer to ours at 11th Street than they are to the original study. So what that basically means is that 80% of your patients are going to have some kind of childhood trauma in their background, and that childhood trauma is affecting their adult health. Okay? So again, evidence, you should go read all the resources I gave you and read up on this. This is absolutely part of your evidence-based practice. So what we do at 11th Street is we do what's called trauma-informed care. So you're not necessarily going to give somebody this ACE questionnaire, although you could, and it is certainly being advocated that becomes part of a regular practice in primary care. And patients aren't going to elect to tell them. Medea is a sharer. That's why I know so much about her. I've also known her for the entire time I've been there. She basically interviewed me. She self-elected interviewed me when I was there for a visit when I was interviewing with Drexel. But she's a sharer, so I just so happen to know all of this information about her, but that's not stuff that I necessarily asked, or that, she just is the kind of person that tells me, right? So you're not going to know, is the point. People can have many of the patients that you've seen have a history like Medea, and you just don't know it because they haven't told you and you haven't asked, and that's not necessarily appropriate within a PT visit. So what we do is we do trauma-informed care. If we know that 80% of our patients have significant trauma, we're just going to basically treat everybody with that assumption in mind. We're going to have the imagination that when somebody comes in and they're being difficult or they're not being compliant or all of those things that we label people with, we're going to keep in the back of our mind that there may be some very complex reasons for that. Okay? So trauma-informed care, the first thing is just be informed. Go read up on this topic and learn about it and understand how childhood trauma affects adult health, okay? And then the second steps of the mental health community is really pushing this idea of universal precautions for trauma. So, we have universal precautions for infection. Even if your patient doesn't have an infection, you're still going to wash your hands, because what if they do? So sort of taking that same approach for your patients. You don't know if they have childhood trauma, but why don't you take some precautions just in case they do, so you're not re-traumatizing them. So the first thing, there's a couple, I put 4 things that you can sort of look at. There's a ton more information about this. I am really just gleaning the surface in the hopes that you will go learn more about it. But safety is certainly a big concern. I mean, the people with a history of childhood trauma have not necessarily experienced safety in their lives, so establishing safety is important. Now, physical and even emotional safety, I think we're very used to thinking about in PT. We're certainly used to thinking about physical safety. We're pretty used to the idea of building rapport and making patients feel comfortable and all that kind of stuff. So I just want to talk about the idea of social safety. So rapport, and it's really just asking you to expand your concept of rapport. Is not something that happens between you and the patient as 2 people, but it is also includes the environment, the other patients, the system you're working within. Like, is the patient comfortable? Can they negotiate the system of wherever it is you're working? When they call up and make an appointment, can they get an appointment? Are they getting somebody on the phone? Are they being told, you no-showed for 3 appointments, you can't come back anymore, goodbye? Those kinds of things. So they also have to have safety in just a much broader sense. And if you can just broaden out how you think about rapport and think about rapport as being the entire system where you work and not just you and the patient, I think that pretty much covers this. Social learning. So this is important, particularly with people who have very complex social situations. So you can teach somebody something. That doesn't necessarily mean they can apply it in their daily life. And if their daily life is complicated, and if they have tons of barriers in their daily life, the real teaching is going to come in teaching them how to apply the information. Giving, saying, hey, you should lift your legs, not with your back. I mean, people already know that. How do you do that? How do you do it in this situation? How do you do it in that situation? How do you do it in your car seats in the middle of your car? Right? So just really thinking about their social context, thinking about the patient within the context of their lives when you're doing education, and really educating for that and thinking about the barriers and asking the patient what their barriers are and then helping them work through it, really taking a problem-solving approach to learning for your patients. Shared decision-making, this is really huge. Don't do to, do with. That concept, I mean, again, it's not a new concept, but it's particularly important in this population because if they're underserved, they're, generally speaking, have not always had the greatest experience with healthcare, and there's been a lot of, do this, do that, do the other thing, lose weight, stop eating bad, goodbye, and you come back a year later, well, you're still eating bad, and you're still heavy, so that's why you still have heart disease, So just a little bit more engaged in the decision making, and I think that we're really used to this in PT from it, like when we take history and we're asking patients for information. What are your goals? Where do you live? What is it like? We're used to all that, but I don't know how well we do carrying it through to like treatment planning choosing an exercise. I mean, if you want to strengthen the abductors, there's 100 exercises you can choose. Why don't you just throw out a couple and let your patient choose which one they want to do, right? I always say your patient should be totally comfortable saying to you, I hate that exercise, pick another. I don't want to do that one, I want to do something else. Like, they should feel comfortable doing that. Because the best exercise, regardless of whatever the literature says, is the one they're actually going to do, right? And then hope. So a little comment on hope. If you look at Medea's case and there's not a lot of hope to be seen there. You're feeling, how am I ever going to help this person? So I think you have to be realistic. You can't say, Medea, we're going to get you to skinny and jogging. It's not going to happen, right? But we can teach you some things that will help you manage your own pain. So give realistic, make realistic goals and give realistic hope. You cannot expect a patient, when they've got all this stuff going on, to go home and do whatever exercises and all that stuff that you've given them if they don't have a reasonable hope that that's actually going to help. So you really need to make sure that your patients have that sense of hope and understand how and why what you're asking them to do is actually going to be helpful to them. So I just want to talk briefly about resilience. Resilience is this concept of, maybe there's somebody with an ACE score of, 8 that ends up being really successful, and then there's someone with an ACE score of 2 that just has a terrible time. So resilience is sort of, how well can you cope with stuff, just to put it plainly. So looking at what are the determinants of resilience, so certainly your ACE score, the higher your ACE score, the less likely you are to be resilient, and certainly the intensity and duration of the ACEs that you've experienced in life are going to have an effect on your resilience. Positive influences on resilience are listed here, so supportive relationships. So you're certainly in a position to be a supportive relationship. You're not going to fix the fact that maybe they don't have any supportive relationships in their family. That's not something you're going to fix. But you can be part of the problem or part of the solution. You can be a supportive relationship or not, right? In your interaction with them. Realistic plans, positive outlook. I sort of talked about those already. Just setting realistic goals and giving people that hope that they can do some things to get to those goals. But also being realistic that they're not going to get to those goals in a couple of weeks. Right? It's like a lot of hard work to get there. Self-confidence, this is just huge because a lot of folks in this with a high ACEs score, a lot of folks with chronicity, a lot of folks who've been underserved, they don't have a lot of self-efficacy or self-confidence, so they don't feel like they can handle all of their problems. They don't feel like they know what to do about their symptoms. So educate, and give people some tools and help them learn how to use those tools, help them negotiate all the barriers they have, and let them have some successful experiences actually managing their symptoms or improving their function or whatever it is that you're working on. Let them have some successes there and build some self-confidence that yes, the things that they're doing on their own, when they're not in PT, when they're not with you, when they're at home, can have a positive effect. Right? So the more they experience that positive effect, the better their self-confidence will be. And then just communication and problem-solving skills, I've really sort of already covered that. But be an open communicator. People, especially folks with the higher ACEs scores, they're perceptive. They have had to be perceptive. They have spent their lives paying attention to who's walking in the door because they don't know who's walking in the door. Are they in a good mood or a bad mood? What's about to happen to me? They are incredibly perceptive. So if you're uncomfortable, they're going to know it before you do. If they ask you if you're uncomfortable, just say yes. You can explain to them why. It's totally okay to be. I always say, honesty always works great. Okay? If you say, no, I'm not uncomfortable, it's not going to, you're not going to build rapport that way. So just be yourself. And this is one of the reasons why I handed you the ACE score. Take it. What's your ACE score? What does that bring to the table? If your ACE score is 0 and you're just super fortunate, fine. That's okay. Just be it. Be whatever it is. If you have an ACE score and that influences you in some way, also fine. Live it, be it, whatever. But just be yourself and be genuine in your communication. And then I already talked a lot about problem-solving skills, but I think that the education is the key, and then problem-solving within that education is important. So I'm going to move a little bit to chronicity. ACE score, people with higher ACE scores definitely have more chronicity. The Institute of Medicine put out this report that's referenced in your references there, but 50% of adults in the US have one chronic illness and 25% have two or more. I think this is the general population. I don't have any data to support this, but I'm going to go ahead and throw out there that in a pro bono and underserved population, those numbers are probably quite a bit higher. Okay? People with chronic conditions increase morbidity, increase psychological stress, right? Because it's not something that goes away. It's something you actually have to deal with forever and ever. More social isolation because they're not getting out as much, less economic prosperity, and then certainly more reliance on themselves and on support systems to manage the problem, right? So if you have a sprained ankle, you can come to PT, I can do all my fancy stuff, and you're going to be all fine, but go back to playing soccer, everything's great. If you have a chronic problem, you're going to come and see me, I'm going to do whatever I do, and then I'm going to discharge you, and you're still going to have that problem, right? So if that's the case, you better have taught that patient what to do for themselves. So I don't have hot packs, I don't have ultrasound, I do almost no manual therapy. You don't do two, you do with, and you give people tools. Okay, so if you're not going to fix it, you got to teach that person how to manage it on their own. And potentially teach their family as well, right? So you looked at Medea's case. You're obviously not going to tackle all of what Medea has going on as a PT by yourself. So for people with a lot of complexity and people with a lot of chronicity, which is kind of overlaps a lot, you really need interprofessional care. Now I'm spoiled at 11th Street because I just have that built in. But what this means for you is even if you're in a clinic by yourself, get to know your community. Find out who else is serving the underserved. Where are your patients getting referred from? Don't just call them up and ask them for a script. Like, go by and visit, get to know them, find out what the community resources are, discuss patients with them. I mean, you really need to build relationships with other people on the team. Can't tell you how much I've learned from all the different people that I work with and the mental health professionals, and just how I can do what I do better because I'm more informed about some of these other things. So Medea certainly falls into this chronicity scenario. She has long-standing problems. She certainly has signs of central sensitization, chronic pain stuff, and she had a lack of early treatment. She's actually did heroin for most of her 20s, so probably as, and I don't know, hard for 30s too. I think she was doing a fair amount of drugs. So some of these problems were developing and maybe she didn't notice, but she certainly wasn't seeking out care. So all of these problems sort of started without being addressed at all, and it wasn't until she was in really more her 50s, but 40s and 50s that she started to seek out care for this stuff. So I want to talk a little bit about goals and outcomes in chronicity, because I feel like this is where people get hung up. Like, oh, I'm just supposed to do education, but my goal should be, a number that got to a lower number, or a number that got to a higher number, or a number of blocks. I need to measure something, right? Because goals have to be measurable. So I'm going to talk a little bit about just what I do with goals for patients. The beautiful thing about pro bono is you really don't have to worry about insurance companies and proving yourself to them. But again, this population also shows up a lot in the Medicaid population, in which case you are still dealing with insurance. So motivational goal setting, this is like a big buzz thing. I think we kind of get this pretty much in PT because our goal is to get people functioning in whatever it is that they do. So obviously we're asking them what they do a lot. So this comes fairly naturally to us. I would just say, like I said before, to extend that sort of information seeking and team back and forth approach throughout treatment, not just in the history taking, but throughout treatment planning. I mean, ask your patient what, do you want to come once or twice a week? Is it hard for you to come twice a week? Fine, come once a week. I'd rather you come twice, but we'll make it work with one. I'm going to give you stuff to do at home, but, come on in, right? So don't just issue your opinions all the time. Give a patient a choice. I mean, how much evidence do we really have that one thing is the thing that needs to be done? I mean, there's lots of flexibility in our evidence, so give that flexibility to your patient. I always tell patients that you are the only one inside of you. So I'm going to need that information, right? And you're going to have to tell me what's working and what's not working, because ultimately they're the only person that can decide that, right? Quality of life, so you're really looking at quality of life with these guys. If it's somebody that you're not going to fix, right, what you're trying to do is you're trying to improve their quality of life. You can't fix it, you're trying to improve the quality of life. So increasing their participation, and in order to do that with somebody who's not getting all the way better, you're probably going to have to do a lot of activity modification, change the way they do something, change how they pace what they do. You know, are you like going to the grocery store and buying hundreds of pounds of groceries and schlepping it all home and then flaring up for 3 days because you did too much, you know, overdo, underdo, overdo, underdo, or are you doing like a little bit each day, which is a much better, less stressful way of getting that stuff done. So talking about pacing and how they're mapping out what they do. Education and health literacy, you know, I always get this education, you know, nobody ever writes educational goals. I think you should write educational goals. I think if they're the only goals you write, that's okay. Look to act, you're all students, right? So you're used to having your education tested, right? You could give them a little quiz, you could do like a lab practical, like here, go transfer that person, you know, whatever. Whatever it is that they're doing, you can ask them to sort of return, demonstrate it. You can ask them to teach it back to you. You can ask them to teach it to a different patient. You know, there are all kinds of things that you can do to measure education, and certainly academia's got lots of ideas, so don't reinvent the wheel. Just look at what academia does and do that with your patients, you know. And then the self-efficacy, self-management. So make behavioral goals about symptom management. So I have a goal that I always write, you know, independent with symptom management. And then everybody, my students are always like, well, how do you measure that? And I say, well, you know, week 2, the patient comes in and they, oh, I had this big flare-up, everything hurt, I tossed, I turned, I did this, I did that, I wasn't even going to come in today because I feel so bad, you know, help me. That's week 2. If I can get them a few months later saying, you know, I had this really bad flare-up, I got in that position you showed me that worked, I did that exercise, I, you know, was going to do this, but I did half of it instead, or, you know, whatever, I, you know, used all of the education you gave me, and, you know, I'm still a little bit sore, but I feel like I'm getting along. They manage their symptoms independently, right? So you just document that. You document what they report when they come in, and you compare the difference of, you know, what you can say. Patient, you know, did lumbar extension, and they laid prone on elbows, and they decided not to, you know, they made their child get up on a chair to pick them up instead of bending over to pick them up, and they managed their flare. You just document what they did, and what you're documenting is that they used the knowledge that you gave them. That is perfectly measurable, even though there's not a number or like a, you know, even though it doesn't have a set value. Perfectly measurable. Totally okay. So I put this up here because when you're dealing, this is the Serenity Prayer as a flowchart. So when you're dealing with somebody like Medea who's just overwhelmingly complicated, I feel like you kind of have to go back to this. So there are going to be things that you can change and influence, and there are going to be things that you can't change and influence. And you're going to have to know which those things are. And it's fluid because you're also, those things might change. So Medea initially may not be ready to work on, you know, problem 35, and so you're working on problems 1 and 2, but later on down the road, she might be ready to tackle that. So what you can change and what you can't change may be fairly fluid. And even if, you know, people talk about things like losing weight, it's so overwhelming when you think about losing. There's just so much, you know, most PTs are like, well, you know, in the course of PT, they're not really going to lose that much weight. Fine. Give them the tools they need to do it. Teach them what you need to teach them. Start. I mean, it's not going to kill you to start. We realize you're not going to finish, but, you know, start. Have that courage to go ahead, even though it's not a problem that you're going to see through to the end. You know, go ahead and start that with that patient. It's okay. So I want to tell you a little bit about what I did with Medea. So these are sort of the questions I asked myself in my mind and then the answers I came up with. So for her, what was the biggest limiter for her? What was limiting her quality of life the most? And for her, there was not one particular thing that was bothering her more than anything else. It was just being totally overwhelmed by everything. That was the thing that was the biggest issue for her. What's the most risky or time sensitive? well, her risk of falls, and she'd had a bunch of TIAs and strokes, so risk of falls and further stroke were certainly the most kind of emergent things that I had to deal with. What was she able to tolerate? 5 minutes on the bike. That's it, okay? So I didn't have a lot to work with. What was she ready to tackle? She was ready to come into PT kind of regular, not when it was raining, not when it was too cold, not when it was too hot, but she was ready to come into PT. And then this is the big question. Are there broad issues that affect multiple problems? Can I kill many birds with one stone? She's got so many things going on. Is there something I can do that's going to have a broad effect on many of her problems? And so she had poor fitness, obesity, low health literacy, poor self-efficacy, or that lack of self-confidence and depression. And cardio. Cardio is good for fitness. Cardio is good for weight loss. Cardio is good for depression. Cardio is good for all of her other like arthritis and cardiovascular disease. All that stuff can be improved with some basic cardio exercise. It fits into what she could do. So that's where we started. Okay, we didn't start by doing a neck eval and back eval and knee eval and foot eval and blah, 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 blah. We just started with some basic cardio. Okay, because that was the broadest thing that we could do that she could tolerate that would just hit as many different areas as I could. So these are just some pictures from 11th Street because pictures are fun. So first thing, always educate, 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 educate. You can educate in a group, you can educate one-on-one, you can educate with 2 patients, educate. Consult and discuss. I never consider myself like the PT that, you're in PT and you are following what I'm putting out there. In my opinion, my patients are their own PT and I'm consulting them so that they can do that well. Right? They're their own healthcare practitioner and I'm their PT consultant. That's really how I view it. So lots of chit-chatting. How are you going to manage this? What are you going to do about that? How do you want to work this? Make them in charge of their own health. Demonstrate. So I'm definitely a believer in practice what you preach. Demonstrate that for patients. I'm always in there. I'm a big eater, and I'm always eating. And everyone's like, "I'm just so skinny, and you just eat all that stuff." I'm like, I play soccer 4 times a week. Fine. People are like, "God, you're rubbing it in a little." I'm like, no, I'm just, I'm being a role model. I exercise regularly, and that's what I want for you. And whatever that means for you, that's fine. But be a role model, okay? We're PTs, so we're gonna exercise. If they want to box. If they want to play ball, let them play ball. And if they want to dance. I'm a big fan of dancing. It's, direction changes. It's got a temporal component. It has everything you could ever dream a balanced program should have. And it's also great if you're trying to spark some neuroplasticity. Dance is fantastic. We always have music on. Sometimes I tie TheraBand to the bike, so there's like 2 TheraBands, and people can dance with the TheraBand and laugh. So I just went over a whole bunch of kind of heavy stuff. Nobody, people with a whole bunch of ACEs, with all this chronicity, with all this heavy stuff in life, like they don't really need to come into PT and it'd be like, oh my God, it's terrible what you're doing. They need to be a little bit light sometimes, so feel free to laugh. So this is a little status update on Medea. Just, her husband came back from jail. I didn't see her for 2 years for the most part, and she's recently come back. So she is doing we have a Power Over Pain group, which is an education group for people with central sensitization. So she's attending that once a week. She's tolerating about 20 minutes on the seated stepper. She's doing, some strengthening and balance exercises. Some days yes, some days no. But, she's doing them. She lost 50 pounds. Looks pretty impressive. She says she feels better, and certainly she's doing a lot more laughing and a lot less crying. In PT, she's definitely a crier. And I put these 2 quotes up because I read those quotes and I feel like I did my job when I hear those quotes, because she said, I love coming to the center. It's a place of learning and healing. I love that she thinks that it's a place of learning. To me, mission accomplished, right? And of healing, not like it's where I go to get better. It's a place of learning and healing, and the concept that that's a process. And then, even though my good health continues to be a challenge, so I haven't fixed anything necessarily, this is the right place to be because I'm learning and healing. So I just feel like those quotes really exemplify that sort of different idea of goal setting. So I just want to talk a little bit about, who should you be if you're going to work with an underserved population? What characteristics do you have to work with this challenging population? And first on that list is perspective. So take the ACE score. I feel like I see this a lot when students come in is, they feel a little guilty. Like, God, I grew up with money and my ACE score is 0 and like my life's awesome and all these people are struggling and they feel guilty, right? In my experience, empathy and generosity do not come from guilt. They come from feeling fortunate. So I would say to you, if you find yourself feeling bad or guilty, try to really convert that to feeling fortunate, Feel fortunate, because fortune, when you feel fortunate, that is when your empathy kicks in, that's when your generosity kicks in, okay? And there's nothing wrong with being fortunate, just be grateful for it, right? Don't feel guilty about it, be grateful. I leave 11th Street every day happy that, my parents respected me, right? Have some good self-awareness, so, cultural competency, I'm not going to even start talking about that because I feel like that comes up all the time. I talked about this alluded to this a little bit earlier, just be real, be yourself. Whoever it is that you are, just be you. I always tell students, being a professional does not mean that you lack a sense of humor and a personality, right? It just means that you conduct yourself with professional morals. You can still crack some jokes, you can still be funny. Whoever it is that you are, just show up and be you, and that's fine. Setting boundaries, so there are a lot of patients with mental health struggles, and sometimes those patients can be a little bit difficult to deal with. So I know we talk about setting boundaries, and I don't always get the impression that people really know what that means. I certainly learned this completely the hard way without any mentorship. It's much easier to learn about it a little bit, but obviously I don't have the space to do that today. But what I would say to you is if you get into an interaction with a patient and you're like, how did I get here? If it starts to feel uncomfortable, that's probably a sign that you need to set a boundary or that you failed to set a boundary. It's probably time to start thinking about what those boundaries should be, okay? Self-care, I already talked about this, be a role model for self-care, but really that's your goal, is to teach your patients how to take care of themselves. And then, just have some lightheartedness. Again, it's such heavy issues and people have so much going on in their lives and you have so much going on trying to help them. So, just joke and laugh and keep it kind of light, have some fun with it. Okay? Thank you very much, and any questions? Yes.
I'm curious in terms of referrals, because it sounds like, and we all have patients very similar in our clinics, but I'm curious, is it getting a referral every month? How do you end up doing that referral from your practitioner, your physician or whatever? And how do you update it? And I'm just curious about that process.
Yeah, we actually, at 11th Street, I actually function more like a primary care office. I never close anybody's chart. All my patients have chronic problems, so why 3 times a week per month, this just doesn't make any sense. I'd rather see them once a month, just ongoing, right? So I never close a chart. It's always open. We have open we don't have to schedule because that eliminates that barrier. So I'm there on Mondays and Thursdays. Just show up when you can. Whenever you show up, you're welcome. I have patients that come in once. I treat them. I never see them again. You think, well, that was a waste of time. But now that I've been there for 6, 7 years, they come back. Sometimes 5 years later, 1 year later, 6 months later, and there's always something that they say, like, I've been doing, I did that one exercise and it helped a little bit, but I still have some pain. I'm like, well, there's some other exercises that are part of the treatment, so we can add one of those now. But there's always something that they took out of it, even if they came once and they don't come back again for 4 years. So because I don't have to deal with insurance, this gets to be really difficult when you're dealing with insurance, but I don't do chunks of PT. As far as I'm concerned, they're just my patient, and whenever they need me, they will come in.
So then you don't have to physically have a referral?
I do. So we have a nurse practitioner run primary care, so they write a referral. I told them, write PT, evaluate and treat, don't give me a diagnosis and don't put a date on it. But I also have direct access, so that hopefully will not be limited in the near future in Pennsylvania. I get a nice generic script, and I can pretty much go upstairs whenever I want and say, hey, will you write me another nice generic script for this year? Yeah.
Okay, that's good. I'm glad to that. And I'm in a state that doesn't have direct access yet, and so it is a different ballgame.
It is.
And I do have a physician that will write me that generic script, and that's sometimes, you come back.
Yeah.
And I feel, anyway, not part of it.
I do have them write it with no diagnosis, because a lot of times they come in with a different complaint.
Right.
So no diagnosis and no, so many times a week for no time frame, no diagnosis, just.
Right. And that is interesting, because they do come in with multiple complaints, but if I want to keep them to their back and it's not on that list of the 5 diagnoses they gave me, I have to write out another.
Exactly.
Right.
Yes. So I do just evaluate, treat, that one. Yeah. Any other questions? Yeah.
How do you connect your patients to things like if they need orthotics, assistive devices? What do you do to connect them to those resources?
So we have, she's asking how do I get people orthotics or assistive devices or stuff like that. And a lot of them are uninsured. Sometimes they're willing to buy it, sometimes they're not. Sometimes that's really challenging. I have patients that need surgery that aren't insured or aren't citizens or whatever. They don't have any papers. So, realistically, they're probably not going to get surgery. I'm certainly familiar with the resources. I do have an orthotist that I've used for the whole 17 years I've been practicing, who is very generous. Orthologics, I think they're the best orthotists around, but they've been incredibly generous with donating stuff for people. I try to save it just for people who really need it. But you just have to know your resources, and you need to sit down and talk to your patients sometimes about prioritizing. We also can sometimes get some donations. If I have patients, all of our patients, we have a pretty nice community going, so if they have something they're not using, they often come and bring it. Hey, I use this walker, I don't need it, can I bring it in? Will you give it to somebody else? We sort of have a nice little community setting. Like people say, my mom passed away, I want to bring in all of her stuff. I'm like, great. So we do have some donations for that too.
The weight loss for the I know was 50 pounds. What was that contributed to, and kind of what's the time frame? Was it she went away for 2 years and then came back and had lost 50 pounds, or?
Yeah, she had actually gained weight and then lost weight. Part of that had to do with some medications she was taking. She got off the medication that was making her gain weight. Whatever, she was already quite heavy when she started that, but. So part of it was a change in medications, but part of it was really that she basically didn't leave the house for 2 years, and then she started walking around, and it kind of melted off a bit at that point. Yeah. She still has a long way to go. All right. Thanks, guys, so much. It was a pleasure.
Thank you, Dr. Wenger. That was wonderful. Good up now. So we just want to obviously help yourself some more coffee, more breakfast pastries and stuff. Just want to let everyone know that we have a ream of paper at front if you want to grab, just take notes if there's not enough on your in your folders and everything. We're going to start to kind of break out into big up. I think we have a little bit of downtime to do the transition, but they'll be in both room C and here. So if you look on your sheet, the oral presentation list, you can pick which one